I've kept up in geriatric practice for over 35 years, and right now part of my practice is just to do fitness work with older adults in a retirement home, and I do assessments and then put together some programs. But I've had experience in home care, I've experience in the hospital and outpatient. I have not worked consistently in a nursing home. I've given talks, but I've never had the privilege of being able to work in a nursing home itself. And being a part of St. Louis SHU and having the familiarity with the Department of Geriatric Medicine has been a wonderful resource. In fact, I told somebody at a talk yesterday that if anybody asked me what were the two most significant things for me professionally, I probably would say being with the Department of Geriatric Medicine has been one, and the other is my own association, the APTA, because they have a geriatric special interest group. So when we look at this, I wanted to start with just some losses that this might be redundant. You might have heard this before. There might be some new things. As I listened to Dr. Morley, it was interesting. I thought, oh, I've heard all this. And then I thought, oh, I didn't know that. And I started jotting down some new things and ideas. I think that this is what happens to us when we go to a talk. We always come away with building up our knowledge so that it's not totally new, but it does, help us a little bit. And then I just want to look at assessment and then look at interventions for this. See if this works out here. Okay. Oh, you have to press it the other way. Okay, so just a little figure here of somebody balancing. This has been an important resource. It's the American Geriatric and British Geriatric Society have given practical guidelines for us, and there's just a recent update, 2010, and it's in your reference list, and it recommends from that, pertaining to my talk, that we do a detailed assessment of gait, balance, and mobility. And one of the things that I pointed out as I gave this talk a while back in April is that we need outcome measures. We need to show we're making a difference, and it's kind of a challenge for all of us no matter what our workplace is. But the thing is that our fall prevention, we have some really strong evidence that we are making a difference when we work with fall prevention with community dwelling older adults. Where we don't have as much strength in the research backing us up is in nursing homes. Are we making a difference when we do our fall prevention programs? And part of the reason is the challenge of working in nursing homes because there's so many complicating factors. It's not a pure looking at somebody with falls, it's looking at somebody with multiple medical conditions and probably dementia that interferes with being able to have some success. So I just wanted to say that's a real challenge for us. So needing outcome measures then, showing the effectiveness. In my talk with you now, I'm really talking about tests for balance, tests for strength, tests for gait. These are our outcome measures. They also can be used for our interventions, so they kind of go hand in hand. Some strength changes that we need just to be aware of. Hypokinetics, just being too sedentary, not getting up, moving around. Sarcopenia, kind of the loss of fibers that we experience, particularly with our fast-moving fibers, so that we don't do things as quickly because of sarcopenia. Then we also see that it takes longer now when we're doing something for a contraction. And remember, as you get older, not only does it take longer to do something, you need more time to relax from it. So you can't expect the repetition that you did when you were younger. The muscle needs a little bit of recovery time that lengthens. And of course, loss of strength and power, we see that. And what happens in some of the muscle fibers is being replaced with fat connective tissue, okay? And the threshold, I love this one because the threshold, how much strength do we need to do an activity changes as you get older. It increases so that we need more strength in the muscle. This one really illustrates that point. It's one of my most favorite PowerPoint slides. It's taken from a study in 2003, and basically what it says is if you're going to look at how much strength, this is just being able to get to a sit to stand, okay? And in somebody who's older, it almost takes 80% of their quadriceps, their knee extension, in order to do that. And if they're going up the stairs, 78% of knee extension, and going downstairs, 88%. The reason it's more going downstairs is a different kind of contraction called eccentric in order to lower yourself down, and so it takes greater strength to do that. In the frail, you may reach a point where they can't do an activity because it requires more strength at that threshold to do it than somebody who's younger. And if they go over 100%, they cannot do that activity. That's why you see older people struggle so much pushing on the chair in order to get up out of the chair, and pretty soon not being able to get up out of that chair. Okay, so that might be, from this study, they felt that this lack of leg strength is one of the key indicators for not being able to live independently and probably having to go that route of assisted living. Now, balance. That was strength, and that was looking at strength. Balance, we know, is just the ability to keep your center of gravity over your base of support. Just kind of remember that balance is both static and dynamic. Static, and it's also reactive and proactive. Static means just standing. Do you have good balance while you stand? Dynamic just means is your balance good while you're walking. But these two things, reactive and proactive, are also important parts of balance. Reactive is you're walking and somebody pushes into you and you lose your balance, and you have to react to that. That's something that you didn't anticipate, and you've lost your balance, and you may end up falling because you couldn't recover. Proactive is just the opposite. You're walking across the room and you see an obstacle in your footpath, and you recognize that proactively and you step around it. That's a different kind of reaction for balance. You're more alert to that ahead of time. These are all the things that can affect your balance. It's so multifactorial. If somebody has poor balance, it takes a long time to really assess somebody. What are the key factors that are causing balance problems? And so you have to look at all these, and I want to address a couple of them pertaining to this talk. The last two, the disuse and the specific disability, I will not be addressing. We know that weak abductors of the hip, our gluteus medius muscle, are kind of vulnerable as we get older. We tend not to use them more effectively as we get older, and we feel that this is one reason why individuals, as they get older, if they don't have some support, tend to fall to the side, okay? And of course, falling to the side and then increases the fracture rate. The next thing was posture, and this is a picture of three individuals. The left one is in their 60s. It's not the same person, by the way. Then the middle one's in the 70s, and the other one is in the late 80s, getting into the 90s. Everyone differs, so it's not fair to say this is typical of everyone, but I do want to point out the asymmetry in the gentleman on the right. And look at the hips, they're uneven. The shoulder height is not even, that one is elevated. Probably have leg length discrepancies. So with posture, you need to look at alignment too to see what's going on here. Are there some changes just even within the bone that causes this to happen here? With sensory loss, we know that the sensory system, all of us are affected by many factors. Vision, of course, is one, and Karen's going to address some things on that. The vestibular system, I'm very interested in that because this is getting to be more and more prevalent now with older people, is the loss of the vestibular system causing dizziness and vertigo. And so there's a whole area that you could test on that. And then the somatosensory system, basically looking at, can they identify at their feet level, can they identify vibration and the position of their feet, and can they feel touch? Now, if you think of your own feet and you like to go barefoot or you wear sandals a lot, the likelihood is that you have built up calluses and different kinds of things that go with pressure, and that your touch sensation may decrease just because of the wear and tear you put on your feet. A lot of time there are just natural changes that occur with aging, and this is part of it, and they just cannot feel with their feet and have the same sensation. Therefore, when they tend to go off balance, they're not even aware of it until it's too far to catch themselves. The reaction time is slower, and all that just says this is probably repetitious for you. It's going to take longer to respond at an older age when they're thrown off balance than it does when you're younger. So we have that. And then the last one here that I wanted to point out is range of motion. If you've got stiff little ankles that don't move very much because you haven't been doing your range and your circles with your feet, you're going to have a problem just recovering your balance at the ankle level because they're just not going to react. The same goes with your knee, and the same goes with your hip. Anytime you lose your balance in standing, that part of the problem besides strength may be that you didn't have the range to recover, that you have arthritis, you have other kinds of things that interfere with that joint being able to recover quickly to keep your balance. So those are some things to be aware of. Now, under assessment, I do put down, and it's not here in your PowerPoint, that if you're going to use some kind of test to assess your folks, you need to make sure it's a test that's out there that is well respected, okay? It's not something that you just put together, particularly if you're going to use it as an outcome to show that you're making a difference. So your assessments should be reliable and they should be valid. And that's why I've given you some references for the assessments I'm using here. And your assessments, people, should be easy to administer. If it takes you too long to do it, you're not going to do it very frequently. You don't have the time. And it also should detect some changes so that, you know, it can have an effect. If you're seeing somebody improve, you can see it within your assessment. And there should be some norms, and I'm giving you in your PowerPoint some norms for my test. So you have a game plan if you're trying to work on improvement. How does it compare to somebody in a norm, you know, value? If you're going to assess strength, there's no PowerPoint here, but the assessments I would use are basically what you use for just improving strength. You can go to doing something with equipment that's very sophisticated, or you can just stay with free weights, or you can stay with TheraBand. But you can determine if somebody's getting stronger just by systematically assessing them with how much they can use weight resistance, and then documenting improvement over a period of time. You can also, and this is what a lot of PTs teaching and now are saying, function is probably more important than documenting free weights. Can they functionally do an activity in a way that's different just because you've been working on strength? So one of my best exercise, no matter at what stage you are, no matter if you're community dwelling or if you're living in a nursing home, is to work on sit to stand. And PTs here might agree with this. Sit to stand to me is so important as far as determining strength in your hips and knees and ankles. It also is a way of determining whether they are getting stronger, because you use it as an exercise and then you time them to see how many times they can do it. So even if they have to use assistance and sit to stand, it's still a very practical, wonderful tool to use. But let's look at some of the balance measurements that I have here. And each one will have kind of a PowerPoint to describe it. Again, you all could tell me exactly what they are, I'm sure, because you use them too. The Romberg and the functional reach and the Berg Balance. Well, the Romberg is just that, being able to work on practicing standing with your feet side by side, or semi-tandem or full tandem. Now, I appreciate the fact that majority of you work in nursing homes. The majority of you are going to work with individuals who cannot do this kind of Romberg test. You're lucky if they maintain their balance with their feet apart, much less put their feet together. These tests that I throw out to you are kind of repetitious for you to hear, but they also may say to you, some of these are a little bit too far advanced. I wouldn't use it with my patients, but if someone was getting better, I probably would go to this. And the Romberg, to me, is a good one to kind of look at here. This one is called the forward reach, and basically it's just what the person's doing. Functional reach or forward reach is being able to stand and shift your weight forward, and now they've done it where they adapt it not only going forward but going sidewards too. So you can do this standing, but you can also do it sitting. Do you have folks that you sit and all of a sudden they're just leaning over because their balance is so poor in the sitting position unless they're propped up? You could work on this too as an intervention, but that's one of the tests that's out there now. And the Berg Balance is developed by a PT in Canada and has been out there for a number of years with good stats behind it as far as reliability. It's just a scale, and if you check it out with a reference, it has some nice activities that go with it, having the person sit, stand, turn, so they're doing all kinds of different motions at the same, and then giving a total score. Then we go to another 3 sets of tests for balance, and here the 4-square test. How many are using the 4-square test at all? How many have heard of the 4-square test? Just a couple? It actually has not been around very much. It came, DITES is the author of this test, and it's in your reference, but it is probably, I'd say, within the last 10 years. I like it because it's a great intervention as well as an assessment. And so I'll show you it in just a second, but then there's timed up and go, and that's being able to sit in a chair and stand up and sit down, and we'll go through that test. And then Dr. Morley's favorite single leg stance. Now, Dr. Morley said to you all, that's one of his most favorite activities. Years ago when he said that, I would roll my eyes and say, we weren't meant to be pelicans. We weren't meant to stand on one foot. This is ridiculous. And I would go back to the fitness class I had in retirement homes and just say, we'll work on something, but don't worry about the single leg stance. I've changed my mind a lot. And the reason I've changed it, I've kind of been looking at falls, and I also have experience with falls, and I realized that's the problem. You cannot balance on one leg. And you turn too quickly, you're on one leg, and boom, you went down. And so to me, single leg stance has taken a lot more importance than I did before. And so I do work on it at a retirement home, and we do time ourselves, and we're trying to push our time on it. Okay, this is the 4 squares test. If you look it up, it's real simple to do, but the little diagram at the bottom is just that. You can do it with canes, or you can do it with just little rod sticks, but you make a pattern like that of at the bottom so that you've got squares, 1, 2, 3, 4 open squares. And then as you do that, and you have the 4 canes, so that you put 2 canes side by side here, 2 canes side by side here. So, if you're in the clinic or the nursing home, wherever you are, canes are always available. And then you have someone, and you show through and you give them directions, and you're showing them how to stand and take a side step, a forward step, a side step, and a backward step. So they actually go from 1, 2, 3, 4, but they keep facing the same direction. They don't turn. They face in one direction, and then they go sideways, forward, sideways, backwards, and then they repeat that. And of course, you're demonstrating. You give them lots of feedback on it. I've used this at senior centers a lot, and it's very good because there's some good evidence now that if a person can't do that, because it takes some cognition along with the physical balance, if they can't do it within 15 seconds, they are at risk for falls. So we're kind of turning to that as a practical measurement for balance here. And then the timed up and go test that I have, this one is basically sitting in a chair, arms crossed over your chest, and standing up, walking 10 feet, turning, walking back, sit down. Now, the problem with the timed up and go, if you go to the literature to look at it, so many people vary it, and they make it 8 feet, then they make it 5 feet, and because they vary it, you can't compare. So this is the original timed up and go, and this is the one that I kind of prefer to use as a test for balance. And then there's the next slide is just more specific balance tests. And this one, the first one, would not be one that I would recommend in nursing homes because basically you're really working on performing your balance activity and obstructing vision at the same time or standing on a big thick piece of foam. That's a much more sophisticated technique that you would use probably out in the clinic. Dynamic gait. This is a particular kind of balance assessment that they actually put together for vestibular type of problems. And it turns out to be a very good walking test, and it has different demands, so that's kind of a good thing to use. And dual tasking, which I'll mention, Dr. Morley's mentioned too, as one kind of a gait assessment that you might want to look at. Dual tasking, all it is just asking you executively to do something different than walking at the same time. And Dr. Morley, I noticed when he had you demonstrate, started with this horrible number. I thought, oh my gosh, I would have to stand there and think, there's no way I could walk and do that task. So I'm thinking that dual tasking doesn't have to be quite that difficult. You can start with something a little bit simpler. You can ask them to count. I've also seen, where what they've done is in the timed up and go, they do it either cognitively by having somebody count, or they might do it manually and have them walk by having them hold on to something that kind of jiggles, so they have to be careful when they're walking with it, and see if they can dual task at the same time. And what do you want to look at? Well, you want to look at the difference between when they did the task without dual tasking, when they just walk, and then how long it took them, and then compare the difference in speed, compare if you had to stop, which you had to stop. So you're looking at some variations. Some people just whiz through it and do it without any problem at all. So, that's one way of thinking about it. Walk while talking. This is interesting. If you see in the mall, sometimes people will tell me, it's really hard for me to walk in the mall because I get distracted and I'm looking in the showcase, and because I'm looking in the showcase, all of a sudden I start to think I'm going to stumble because I'm not concentrated on walking. People sometimes have a hard time. I have a hard time myself in being diverted in my attention. If I concentrate on walking, I do fine. As soon as somebody's talking to me and they want to ask me questions, I tend to feel a little bit more shaky, and that's part of the dual task. You can work on it, but it also says you have trouble with it, okay? You may have somebody talk to somebody about their medical condition. Tell me what's going on. When did you first have this problem? And meanwhile, you're walking across the room. They may have to stop and tell you first, okay? So that's a clue that, that's a problem there. Okay, these next two slides, I won't spend time on you, but those of you who want to know norms, here are the norms. These are the things, the values that says, if you do this, if you can't reach at least 6 inches, you're at risk. And these are tests that people have validated with repeating them over again. If the Berg Balance, that's a score. If it's less than 49, you're at risk. Gait speed, if you walk less than 0.42 meters per second. And sit to stand. I love this one. The 3 sit to stand, giving the same directions, and they stand up 3 times in a row. If it takes longer than 10 seconds, they're more at risk. And then these are the next here, and I mentioned the 4 square test. Timed up and go, getting up, walking the 10 feet, coming back, sitting down. If that takes more than 10 seconds. And single leg stance. Okay, how long should somebody normally be able to stand on one leg? And supposedly in the test itself, the way it was devised, it should be 20 seconds. I don't have anyone who stands on one foot for 20 seconds. This is independent living retirement. They cannot maintain it. But I do know that if they can't do it for 5 seconds, they are at risk, okay? So we're just working at improving from 5 to 10 seconds. That's our goal here. Okay, so those are some norms that might help. And then looking at gait, these are the changes that happen with gait. You're going to walk with a wider base and hold your arms at your side, have a slower speed, and do all these different kind of things. And you obviously are going to have more deviations and have more poor endurance. The St. Louis Post last winter when we had the ice ran this article, boy did I clip this out, on what you should do if you have to walk on a slippery surface, meaning, quote, your driveway that's got an ice coating on the black asphalt. And basically they showed you things that look exactly like what gait changes look like. They said slow down your speed, okay, keep your feet way apart, take little tiny steps, actually take steps with your knees bent a little bit so you don't, and if you have to go down sideways. If there's a little bit of slope, take steps sideways. Don't go forward because that could start you on a momentum. And then you use your arms to balance. So you hear you when you hold your arms at your side. So I use that because I think for community folks that's important to point out. Now, gait speed can predict those at risk for falls. We had an article in the PT Journal called Gait Speed, the Sixth Vital Sign. And I went, what the heck is that? And turning it into looking at it, it really does reveal an awful lot how people walk. If you have some very slow ambulators, they may be more at risk for falls just because their speed is so detrimental for that. And I'll show you a slide on that. If you're in the community, and I'm going to rush through this because you folks are mostly interested in the nursing home, but you do need to ambulate about 200 meters. And if you need to cross a street, you have the traffic light is going to not be in your favor if you're a very slow walker. But what I was reading with Ann Shumway-Cook, who does some research on this, is that most older people, really, if they have a problem with their gait, they're not worried about traffic lights. Actually, they're just going to places where they're parking in a parking lot and getting into a store. So maybe this isn't so relevant to them, as somebody else. And you need to just look at all the other things that might affect your speed, and that are mentioned here. And if you are interested in doing a gait speed test, I really think that the best test to me for my use is called the 10-meter walk test. It doesn't take forever, okay? Now this slide and the next slide I'm going to show you are not in your PowerPoint because I just put it together the other day, pulling it together from Gait Speed article. But the 10-meter walk test is just 5 meters before as you accelerate, 10 meter, and then 5 meters after that as you decelerate. It's a quick way to assess gait. So if you did community screening, this is a good way to assess speed. In your situation in the nursing home, you're looking forward to more balance and stability, not how fast they walk. But keep in mind, the slower they walk, the more difficult they may have in being able to maintain their balance just because of some of these factors here. And then you can look at assistive devices. Important to have appropriate assistive devices. And as mentioned before, working with walkers, crutches, and canes. I'm not a real big fan of tripod quad canes only because I found as one gets older it gets more difficult to keep those things upright and use them effectively. I love walkers because I know they're more bulky but they're so stable, and I tend to just favor working with a walker a lot of times because of that. The same, I'm not a big fan of crutches because at this point in life you're putting so much weight on your wrists. And it's difficult to use crutches correctly. So I guess I go back to just thinking about walkers as being a real nice device here. Okay. Now, interventions, very quickly on this one, our interventions are basically our tests we can use as our interventions too. Being aware of compensation and then working on interventions to improve all these things. So let's just look at this real quickly here. I want to say something about compensation. And again, this came from looking at some of the studies on individuals who tend to hide the fact they're having more trouble doing something. It's called preclinical disability. It's being at home and you're really worried somebody's going to notice something and think that you're going to need more help and may even have to go into some kind of assisted care. So you start avoiding things, okay? And here, this is, you know, you may start doing something in a different way. Gosh, I'm having trouble getting out of that chair. So all of a sudden I'm turning to my side, I'm leaning on and getting up, and nobody's noticed me doing that, but I simply can't get up in a straightforward manner anymore. If there's the day where I can't see well, my glasses aren't, you know, adjusted correctly, I can't do it at all. So I'm relying so much more on other cues. I might do something a lot slower, and I might just do it less frequent. Oh, that's just too much trouble. I'm not going to go, you know, I know you want me to go with you to the Walmart, but it's just way too much trouble to get in and out of the car. It's way too much trouble to walk at Walmart because it's too big of a store. So you start eliminating things that you challenge yourself to do before, you just don't do it. And then making the environment easier, okay, so that all of a sudden you don't have to do it. You call in and you have people to run your own errands for you, so you don't have to do that task. Or avoiding the task. How many times I said to somebody that I first started assessing, do you have any trouble going up and down stairs? And they said, no. What do you think the reason is? They don't do it. If I had just asked that question a different way, sure, they don't have trouble in a lot of these things. You know, do you have trouble going to the airport? Do you have trouble going up the escalator? Oh, no, not at all, because they find the elevator and they go up on the elevator and down, which is okay, except that what they've done is eliminated some of these things and then said, I'm still okay, but I didn't have to do it. Now, the thing for me to realize is you cannot totally change compensation. If you learn to do something differently, okay, and it works for you, and this is the way you go up and down one stair or into a different room, maybe keep that compensation. If it works well and it's safe, let the person do it. A neighbor of mine had terrible arthritis in her knees, and how she did tasks were just unreal. But she needed to be able to do the task, and she felt so proud. Let her do that. Compensation itself may have a reason behind it. Okay, so here we go with interventions. And again, I'm just keeping this real basic. If I wanted to work on strength, I would do sit to stand, okay? I might stand and have people rise up on their toes and back on their heels. Short squats, I really believe in that because that's, you know, a short extension movement that you're doing, and it's eccentric contraction, and it's a wonderful strength for your legs, okay? And I like TheraBand because it's so easy to bring with you and use, and folks tend to understand it a little better. They're a little scared sometimes of doing free weights, that it might drop and might hurt them. Range of motion, of course, all the kind of stretches that you can do. You can devise the things that work for yourself that you might be thinking might be a problem with this person. You might want to do it. Here, you know, this is to stand, and of course, leg exercise. This is my favorite hamstring stretch. I use it all the time. I do not have somebody stand and try to touch their toes. I don't want them to do that, but I do want them to stretch their hamstrings, so if they sit erect and straighten their knee and pull their toes back, that's a wonderful hamstring stretch, and it's a safe one to do, and they tend to do it well. Balance intervention, of course, the same kind of thing, standing, eyes open, closed, doing these kind of activities here, modifying it. And you can do this and work on these things, or you can kind of vary them. You can practice that 4-square test, you know, and make that your intervention so that you have something for them to work with. And then the gait, just trying these different activities. You all could add to me millions of things that you think might be helpful for your patients too. Things that you've tried or things that you even do yourself that you find that's really helpful. I'm really big now on marching. And I know that sounds dumb, but I do have osteopenia. I'm very worried about osteoporosis. And I know that resistive exercise is important. And I know Dr. Morley mentioned vibration. but we need impact on our bones. And everything that's coming out now under human kinetics is saying, you're not cutting it. If you're just doing weightlifting, you have got to have more impact on your hip bone, on your femur. And so marching to me is a good one, because walking puts an impact, but marching makes it even more effective. And you can do it to music, and it's kind of, you know, fun to do. So that's one thing. And then also, if you're working on walking, your folks are at that point that you can do that, have them work on changing directions, have them work by walking around obstacles. These are all kind of good clues for you. Of course, you know, any kind of balance system that you could use, using these balance balls is good. I would caution anyone doing this at the retirement home that I'm at. We had an injury, I wasn't there. They had an exercise room. A little lady went down there, she sat on this ball, and the ball went out from under her, and she fell down on the floor. This to me is a good example of, we promote wellness and we promote exercise, but if it's not supervised, that it can be a problem and dangerous. And then of course, Dr. Morley mentioned Tai Chi too. And then we have all kinds of things out there, you know, to alert you in general technology if somebody's at risk for falls, whether they're in a chair or their bed or just even walking. There's some sophisticated things now that we look at in walking to see if this individual is at risk here. Okay, I am done.